record it. There we go. Okay, so I thank you, Dr. Annie Lynn, for being here and spending this time with us. Dr. Lynn is a movement disorder specialist at the University of Washington Medical Center here in Seattle. And she is fellowship trained in movement disorders. So basically what that means is she became a neurologist and then she specialized in movement disorder. So she's done extra schooling and is up to date on the latest and greatest in Parkinson's disease. And so she sees folks in the clinic, and I don't know if you do research anymore or you used to, or I'm not really sure, but she's been involved in a lot of different ways in movement disorders. And so and as well as educating new neurologists coming into the field. So we are very lucky to have her share her knowledge and information. So thank you, Dr. Lynn, for being here.
Hey, everybody. It sounded like we're coming from all different parts of the country, maybe the world. So hello from Seattle. And let me share my screen again. And Jen, tell me if I'm doing it.
Yeah,
right.
I'm going to mute everybody. You might have to unmute yourself, Annie.
Oh, can you hear me?
I can hear you, but I haven't muted everybody yet. Hold on.
Okay, got it.
Here we go. We're muting y'all.
Okay.
And you will need to unmute yourself.
Okay, I think we're good.
We are great.
Okay, perfect. Everybody can see the slide and can hear me okay? Perfect. Thank you. Okay, so just like Jen said, feel free to sort of interrupt me or ask me to repeat something if you have a hard time hearing me. But I am going to be talking about Parkinson's disease today. And in my practice, a majority of my patients are patients with movement disorders. So that means Parkinson's disease, Parkinson's related disorder, like, Parkinson's plus syndrome, and other type of tremors. So again, just definitely let me know if you have any questions or you wanted me to sort of go into a little bit more detail. There's going to be a lot of information covered both today and tomorrow. Tomorrow, we're going to be talking about mostly medication and a little bit of other treatment strategy, but we'll also be a little bit of a sort of a quick review of what we talked about today as well. So here we go. So let me see if I can move forward. There you go. Okay, so we are going to be talking about what is Parkinson's disease, what are some of the symptoms associated with Parkinson's disease, and just in case some of you may not be able to join us tomorrow, there's going to be a very brief, a couple slides talking about sort of the bigger overarching themes about medication management and treatment strategy. So Parkinson's disease, the many symptoms of Parkinson's disease is known in the medical field for a long time, but it is not until 1817 when Dr. James Parkinson wrote an essay that actually put all of these symptoms together into one disease process. In his essay, which is called An Essay on the Shaking Palsy, he describes 6 different patients who has very similar symptoms. Out of the 6 patients, he only really follows 3 of them in clinic, so he was able to describe them in details. But the other 3, he either sort of just briefly chatted with them about their symptoms, and then there's actually one of the 6 patients that he written in his essay, which is somebody that he casually observed from sort of far away, but that also shares similar characteristics. So because he had such a good, accurate description of this disease ended up being named after him, and now we know it as Parkinson's disease. So Parkinson's disease in sort of our medical world is known as a neurodegenerative disorder. It's a big and long word, but essentially means that it's a degenerative disease, meaning it's a disorder that slowly gets worse with time, and it's a neurological disorder. Currently, there is not a known medication or surgery that can cure Parkinson's disease or can stop Parkinson's disease from getting worse. Parkinson's disease is also the second most commonly diagnosed neurodegenerative disorder, right after Alzheimer's disease, which is the first one. In the year of 2016, there was estimated to be around 6.1 million people around the world affected by Parkinson's disease. Population projections show that by 2030, which is not too far away, about 10 years away from now, there will be just in the United States 1.2 million Americans affected by Parkinson's disease. When they look at the cost of Parkinson's disease, is estimated just within the US alone, they will be costing about $52 billion per year. This is both direct costs, meaning costs that associated with medications, associated with going to see doctors, etc., but also indirect costs, which are monies that you may need to spend remodeling the house, time that you or your family need to take off from work to go to doctor's visits, to participate in physical therapy, etc. So it is really quite a costly disorder. The average age of onset for Parkinson's disease is around 60 years of age, but there is a small population where their Parkinson's may start earlier, as early as in their 20s and 30s. And in these people, we classify them as young onset Parkinson's disease. So the exact reason why you have Parkinson's disease is still unknown. Right now, so doctors are giving this hand wavy kind of answer, oh, it's probably likely a combination of gene and environmental factor. What we know is that aging is one of the strongest risk factors for Parkinson's disease. So when you look at the population of 65 and above, the prevalence of Parkinson's disease is about 1 to 2% in this population. But if you narrow it to only look at people who are 80 and above, the number actually grew to about 4%. So as you see, the older you get, the higher risk of developing Parkinson's disease. There's also has been some sort of association with other potential risk factors, such as pesticide exposure. For those people who sort of have connection with military, know that Agent Orange, pesticide sort of exposure over in Vietnam War, is a known sort of link to Parkinson's disease. People with traumatic brain injury. So if you think about Muhammad Ali, who has sustained likely a lot of traumatic brain injury from his career, is also a higher risk of developing Parkinson's. Excessive body weight, certain dietary factors are all may sort of increase certain people's risk of Parkinson's. However, not all people who are exposed to pesticide or has sustained traumatic brain injury will develop Parkinson's. So there's only sort of one risk factor, and there's probably a lot of other maybe genetic or maybe some other environmental factors that is at play that we still don't know. Less than 10% of Parkinson's cases are actually due to a pure genetic component. These kind of patients tend to present at a younger age in their 20s and 30s, and they usually have a very strong family history of Parkinson's disease. So their parents, their siblings, grandparents may all have Parkinson's disease, sort of you can clearly see in a family tree. So when we sort of study a little bit more about Parkinson's disease and what is happening in the brain, what we do know is that Parkinson's disease is because of the cells in the brain that produce a chemical called dopamine is not working as well. They're either dying or they're impaired in the way that they're not producing as much dopamine in the brain. And then the reduction of dopamine is what ended at the end of the day causing the symptom of Parkinson's. When we look at these cells under the microscope, we see that there is a abnormal sort of protein that accumulated and gets stuck in these cells. And these proteins are called Lewy body. And then we don't really understand why some people develop these Lewy bodies and why these Lewy body particularly targeting these dopamine cells. And these are sort of things that scientists are still working on to try to help us understand a little bit more about Parkinson's disease. So what are some of the symptoms of Parkinson's disease? So when we think about symptom of Parkinson's disease, we sort of think about it in two different categories. One are the motor symptoms, and then the other ones are the non-motor symptoms. The motor symptoms are what some people can see when they look at you. So we sort of put these symptoms together into a mnemonic called TRAP, T-R-A-P, which stands for tremor, rigidity, akinesia, and postural instability. And we'll talk about all of these in a little bit more detail. But another sort of key point about Parkinson's motor symptom is asymmetry, because I actually see a lot of patients in clinic, they ask me, why is one side worse than the other? And we tell them that that's actually the more common thing in Parkinson's patient, in that one side, whether it's the right hand or the left hand, generally is a little bit more affected than the other. There are a smaller population where they're equally affected on both sides, but they're not as common as those people who are generally more affected on one side of their body than the other. So let's talk about the TRAP individually. So tremor is probably the most sort of classic symptom that we think about when we think about Parkinson's disease. And it's also the most common reason that people get referred to a neurology clinic is that, hey, I developed a tremor over the past year, over the past 6 months. Do I have Parkinson's? So the type of tremor in Parkinson's patient is what we call a resting tremor or a pill rolling tremor, which means that the tremor generally happen when you are relaxed, sitting on the TV, sitting on the couch, watching TV, walking when you're not paying attention to your hand and your arm is truly relaxed. That's when the tremor came out the most. It is also a pill rolling type of tremor, meaning that the tremor generally is a smaller amplitude and is further away from your body. So more distally in your hands and your fingers, almost like you're rolling a pill in your hand. So that's the most classic form of Parkinson's tremor, is a resting tremor and a pill rolling tremor. The tremor may get worse or change characteristic over time. Some patients' tremor actually may start off as more of an action tremor than a resting tremor, which means that the tremor that somebody noticed first is when they're doing things like holding a pen, when they are holding a cup or a spoon in their hand that they tend to shake. Sometimes this can be a little bit confusing to the doctors because it can look a lot like essential tremor, which is a different type of neurologic disorder that is only related to tremor and not associated with other symptoms that we think about in Parkinson's. But then the classic type of essential tremor is an action tremor. So initially it can be sometimes hard to figure it out from a neurologist, but we also look at other symptoms like slowness and stiffness to help us with the diagnosis of Parkinson's disease. So this is a video, hopefully this will play, that is showing sort of the classic type of resting tremor in Parkinson's patient. And I'll try to play it twice because it's kind of short. It's in his right hand. You can see it's a smaller amplitude and it's only in his hand. It doesn't have a shoulder involvement, and I'll play it again. So this is a classic resting tremor. These type of symptoms generally start with one limb, more common in the hand than in the leg, and then it may eventually become bilateral, but still stay worse on the side that started first. And then the other thing about tremor is that there is about 30%-ish of Parkinson's patients that actually never have tremors in their lifetime. So tremor is really not a requirement, but it's a fairly common symptom that we see in Parkinson's patients. The second symptom in Parkinson's disease is something called rigidity, which really just means that stiffness in the muscles in the joints. Sometimes this rigidity can also cause cramping or changing in somebody's posture if it's affecting more of your spine, that it can cause some people to be more stooped and lean forward. A lot of the time, because we're looking into a more elderly population when we're thinking about Parkinson's disease, osteoarthritis is also very, very common. So when somebody feels like their joints are stiff, their joints are, a little bit not sort of working as well, they may first thought about, oh, maybe I need a shoulder replacement or hip replacement. But with physical exam and sometimes really with a little bit of a time, then we realize that we're really dealing with more of a Parkinson's disease than true arthritis. So this is an example of a patient who has rigidity, and we're testing in his neck. So I'm going to jump forward a little bit, actually. Let me see if I can. Maybe I can.
Cardinal signs of Parkinson's.
I'm going to skip out of this page a little bit just so that I can jump forward a little bit to show you the rigidity. Okay.
Marked a resistance to passive movements.
So,
and I'll just attempt to demonstrate.
He's going to be moving around his head, and then you can see that the neurologist needs to put in a little bit more force when he's trying to move his head around. And that is the rigidity that we are looking for when we're testing you in clinic. So we generally test it in the bigger joints. So in your head, in your wrist and your elbow, as well as in your leg. That's what we're looking for in rigidity. Am I back to the presenter mode or the bigger page? Hopefully I am.
Yes, you are.
Okay, great. Okay, so next is bradykinesia or akinesia. So this is essentially another fancy word, but really if you break it down, it means slowness in movement. When people have bradykinesia, which is a hallmark of Parkinson's disease, this is a symptom that everybody must have in order to achieve a diagnosis of Parkinson's disease. It's a slowness of movement that can really affect globally or a particular part of the body. So when it is affecting globally, people can feel like, they're moving a little bit slower, they're getting their chores done a little bit slower, they're walking a little bit slower, they're getting dressed and showering and brushing their teeth. Overall, just seems like everything is in slow motion. When it's affecting people's facial expression, it can make people's facial expression look more like poker face, or it doesn't have as much blinking, doesn't have as much animation when you're talking to somebody and having a communication with somebody, conversation with someone. The slowness can also affect people's voice. So it would translate into people talking slower, people talking in a softer voice. And a lot of the time, families and friends may say, "You're mumbling. Can you speak up a little bit?" When it's affected in handwriting, that can translate into a change in your handwriting. The most classic in Parkinson's patient is that when you're writing, you might start off with bigger letters like you normally would, but the more that you write, your letter gets smaller and smaller and smaller as it goes, and it may actually look like chicken scratch. So that's when the slowness of movement is affecting the handwriting. When you're walking, you might not be swinging your arm as big as you would 20 years ago because the slowness of movement is affecting in your arm. When bradykinesia is affecting your lower extremities, that is really the bigger change that causing in terms of changes in your gait. So you're walking slower, you're not picking up speed as much. It's harder for people to get in and out of the chair. All of these are really due to bradykinesia or slowness of movement. So next is going to be also a video sort of showcasing some of these symptoms. So first, we wanted to pay attention to his facial movement. Let me mute this a little bit so I can talk over him. So you can see that he's actually not blinking very much. And then he's also not having a lot of movement around his mouth, where he generally just kept it at that sort of position. And he really is not blinking very much at all. Your doctor may be asking you to do some of these testing in clinic, where they ask you to open and close your fists or tap your fingers. And as you can see in this gentleman, he's slower on one side, but on the other side, he's even slower. And this is the asymmetry that I also mentioned earlier. Similarly, when we're asking him to do a different kind of task, when he needs to repeat it back and forth, he also have a more challenging time, slower in doing on the other side as well. And it's not as accurate on the other side. So this is how we test for slowness of movement, bradykinesia in clinic. And again, this is the hallmark of Parkinson's disease and is the required symptom to have in order to get the diagnosis of Parkinson's disease. So gait and balance change is also something very common in Parkinson's patients. This is due to both the bradykinesia, which is when this affecting your leg is causing the slowness of movement, but there's also a part of Parkinson's disease that is actually changing your perception of balance and changing your steadiness on your feet as well. Patient may report that they're shuffling, they're not picking up their feet as much. They can't take as big of a wide step when they're walking. Sometimes patient may complain of something called freezing, meaning that when they wanted to start walking or they're already walking, suddenly their leg just gets stuck and it's hard for them to sort of take the next step. And then they may struggle and take smaller steps before they can get going. Another Parkinson's gait symptom is called fascination of gait. The way that I sort of envision or describe it is that almost like your upper body is trying to go faster than your leg can keep up. So people are just leaning forward more and more as they walk, and then they're taking smaller and faster steps trying to catch up. But sometimes this may lead to a change in center of gravity and people may fall forward because of that. So here's an example of a gait change in Parkinson's patient. So you see that the step is pretty small, is leading with one leg more than the other. And this is where he sort of gets stuck and wanting to go forward, but have a hard time doing until he can sort of figure out a way to lead himself forwards. So we can play it again. So this is the freezing of gait, what he demonstrated over at that patch of a pattern change. So as I mentioned earlier, in addition to a change in the way that people walk, there is also a change in people's sense of balance. Early on, this change may not be very noticeable. It's just sort of a vague, oh, I feel a little bit off balance, but walking is completely fine. There's no problem with running and working out and everything like that. But in patients with a little bit more advanced Parkinson's, they sometimes may complain of balance change where it's harder for them to catch themselves when they're falling, or when they're standing, they just feel like suddenly they're going backward without a really clear reason. The way that we test it in our clinic is by doing what we call a pull test. That's going to be demonstrated here. So we essentially do a light pull from the back, and then we'll see how many steps that a patient needs to catch themselves. Sometimes there's, you take one step. In normal people, you don't need to take any step backward, or you take 1 or 2 steps backward and you're able to correct yourself immediately. That's really great. Some patients may need to take a few more steps, but they're able to eventually to correct themselves. Some patient will fall if the doctor doesn't catch them from the back. They would not be able to correct themselves. And in more advanced cases, certain patients, when they're standing, even without us pulling, they can spontaneously start going backwards, and then leading to a fall that way. So going backwards is never a really good idea in Parkinson's patients. Any questions about what I just talked about in terms of the motor symptom? Those are the key sort of motor symptom in Parkinson's. Any question before we move on?
There was one question in the chat that I just saw, and now I've lost the chat. There it is. So Barbara wanted to know, is dopamine produced elsewhere in the body? And does this production also decrease in PD?
So dopamine is mostly produced in the brain. There are certain sort of dopamine activities in your gut and other places, but I think what we're seeing mostly is the effect in the brain. And many of the non-motor symptoms that we're going to talk about a little bit too are also related to the sort of dopamine pathway. Yeah, and I'll stop there.
Okay, thanks.
So moving on to sort of the non-motor symptoms. So what a lot of people think about when they think about Parkinson's disease are, oh, walking is chained, oh, where you're shaking in your hand, but really there's a whole lot that people cannot see that is also related to Parkinson's disease. It's not even, I think, the full list, but there's many other symptoms that Parkinson's patient can complain of. And these are what we called non-motor symptoms. And sometimes these non-motor symptoms are can be even more bothersome or interfering with somebody's daily life more than their motor symptom. So we're going to sort of go through the bigger categories of these symptoms. And again, just stop me or let me know if you have any question about any of these specific categories. So gastrointestinal symptom is one of the very common location where we also see a change related to Parkinson's disease. The most common symptom by far is probably constipation. Constipation affects at least 80 to 90% of patients with Parkinson's. Sometimes constipation can show up even decades before people develop a tremor or a gait change in Parkinson's. Because constipation is also very common in the general public, we can't exactly looking at a 40-year-old who comes into their primary care doctor's clinic complaining about constipation and tell them that in 20 years they're going to develop Parkinson's, because there's a lot of other reasons that people can have constipation. But when we look at a population of Parkinson's and look at their history, this is when we realize the high link to constipation. Constipation can sometimes also develop after the Parkinson's symptom has already kicked in. So it's not something that always happened before, but it can also happen after. When we think about sort of the gastrointestinal, there's more than just bowel movement. So sometimes people can also complain that, they feel bloated very easily, or that after they eat a small meal, they feel really full really early. In later stage, some patients may also complain of trouble with stooling or even trouble with swallowing. The way that I explain to my patient is that when you think about your guts, they are controlled by a lot of different muscles that are sort of trying to squeeze things through from one end to the other end. And then these muscles also slow down from the Parkinson's disease. So when the muscles slow down in the stomach, you might be eating a few bites, but because they're not getting through as fast as they would be when you're younger, but without having Parkinson's disease, they tend to sit in the stomach a little bit more. So people get full a little bit early. And the slowness also translates into constipation as well, and the bloating. when you are when you the sort of the slowness also affecting your swallowing. So you're still producing the same amount of saliva in your mouth, but people may not be swallowing as much from Parkinson's disease, and that leading to pooling of the saliva in the mouth, which can then lead to drooling. The other thing that we sometimes sort of think about is that also the gut function also impact on how well the medication is working. So some patients may feel like my medication is not sort of working or kicking in as expected, or I'm wearing off earlier than I used to. This may also be related to some of their gut function as well. So it's really important to sort of pay attention and know about these potential symptoms, making sure that you're well hydrated, because that's going to be a very important key for minimizing constipation, is keep hydration. We usually recommend at least 1.5 to 2 liters of water a day if you don't have a cardiac reason or other reasons that need to sort of not drink as much water, but we recommend keep hydration. Minimize things that sort of deplete water from your body, like caffeine, like sugary drink. Making sure that you're taking high fiber food to help the gut sort of moving. Sometimes people may find probiotic helpful as well to keep their sort of bowel regimen regular. And it's stuck. There we go. So the GU system, the genital urinary system, is also a system that can be affected by Parkinson's disease. Sexual dysfunction is something that you don't always talked about with your doctor, but I wanted to say about 35% of patients can complain of sexual dysfunction, whether it's loss of drive, reduced libido, or erectile dysfunction. Sexual dysfunction can also happen in setting of medication side effect, but then usually it's on the opposite end of the spectrum, where people can have more hypersexuality related to the medication used in Parkinson's disease. In terms of urinary function, early stage people can complain of more of a frequency, especially overnight. They need to go to the bathroom a little bit more frequently. Later, they may develop what we call urgency, meaning that when I have to go to the bathroom, I have to go to the bathroom right now. I can't wait. If I wait, there may be leakage, or maybe having incontinence that happened. A lot of these are symptoms that sometimes people may not volunteer when you go to the clinic, but make sure if it's bothering you or you're noticing these symptoms, talk to your primary care doctor or talk to your neurologist, because there may be some medication that we can help to minimize some of these symptoms. That is not just sort of the pure Parkinson's medication that we think about. Orthostatic hypotension is also another symptom that we consider as a non-motor symptom, and that can be quite bothersome or limiting to certain patients. The orthostatic hypotension, meaning that your blood pressure suddenly drop when you are changing position from either a lying down position to standing up, or from a sitting position to standing up. So this means that the gravity is fighting against you and trying to pull all your blood down to your leg when you're standing up. But because of Parkinson's, you have a harder time regulating your blood pressure control. So all the blood actually went to the leg and not going to the head as much. So people may experience lightheadedness or feeling off balance when they sort of change position. You're at higher likely risk of developing hypotension, orthostatic hypotension, if you're older age or you have longer disease duration. We tend to see this a little bit in more advanced cases and not the early milder symptom of Parkinson's. This can especially get worsened if you're also taking blood pressure medication, which is very common. As people get older, they may develop high blood pressure, and then they may need to be on a medication to control that. And actually, Parkinson's medication itself can also cause lower blood pressure. So usually when we see patients in clinic who's complaining of lightheadedness, feeling off balance, especially when they're just getting out of the bed or standing up from a chair, we look at their medication and making sure they're taking appropriate amount of medication, whether it's blood pressure medication or Parkinson's medication. Then we talked about sort of different conservative measures, such as hydration. Again, if you don't have a sort of heart reason or other reason that, that won't allow you to be drinking a lot of water or taking enough salt, we sometimes actually ask you to sprinkle more salt in your diet so that you can keep more water in your body. Sometimes we talked about wearing compression socks, either to the knee or to the thigh. And sometimes we even added something called abdominal binder to provide an external squeeze so that your blood can stay in the brain and not all fall to the leg when you stand up. In more severe cases, we talked about adding blood pressure medication that actually boosts your blood pressure, raise your blood pressure up to support you so people don't feel like faint or passing out when they're standing up from dropping their blood pressure. Mood disorder is ranked among one of the more troublesome non-motor symptom in Parkinson's patient. It can range from depression, anxiety, or apathy, loss of motivation, loss of the drive to do something. Many of these Parkinson's patients may report depressive mood, although only a small minority actually meet the clinical diagnostic criteria for major depression, but it's far more common to just feel like I'm not as happy, I'm feeling a little bit more sad, or I'm just a little bit not as interested in doing things. Similarly, anxiety can happen in about 30 to 40% of patients. Many of these mood symptoms can actually happen many years before their Parkinson's disease started to happen as well. So like the motor symptoms started to kick in. And this is a lot also probably related to the dopamine changes in the brain. There is not really a specific Parkinson's medication for depression or Parkinson's medication for Parkinson's anxiety. We're still treating it with a similar kind of medication that we have for people who does not have Parkinson's disease. So a lot of the time it's also a trial and error process with your doctor to figure out what is the right medication for you to help sort of reduce some of these symptoms that is happening. Psychosis happen in a small group of Parkinson's patients, and this generally happen at the later stage, more advanced stages in Parkinson. It is not something that would happen in everybody, but we do see in a group of patients. It is important because psychosis is the single greatest risk factor for nursing home placement, which is a little bit surprising because people may think about, oh, it's because people are falling all the time, needing to be in a wheelchair all the time, but really it's because of the psychosis and difficulty to manage all these behavior changes at home that leading to people needing to be placed in a nursing home or a group home because the caregivers may have a hard time sort of handling these symptoms at home. The most common psychosis in Parkinson's patient is usually visual hallucination, so seeing things that are not there. And the type of things that people see generally is a little bit different, is that they usually describe a very vivid image. So whether it's seeing a cat or bug or a dog or anything running around the house, or sometimes as vivid as, one of my patients described seeing an Indian chief with the whole full headdress and everything standing in the middle of the room in the middle of the night when she went to the bathroom. So these images that people see are usually very vivid and in great details. The other type of psychosis that can happen is called delusion. So meaning that there is a fixed belief about something that is really hard to convince these patients otherwise. So despite having a lot of different evidence to say this is a wrong belief, it is very hard for these patients when they have delusion to really see the evidence. And if delusion is going to happen, more generally is more paranoid in nature. So like believing people or family are stealing money from you, believing that the spouse is cheating on you, etc. Those are the more common type of delusions that we see if it happens. There is actually a medication that is specifically for Parkinson's psychosis that was approved, I wanted to say maybe 6 years ago or so now, that is sort of an added arsenal to a list of medication that we use off-label to sort of help sort of manage some of these psychosis symptoms. Sleep disorder is also very common and sometimes a symptom that people just don't talk about. They seem to feel like this is something that they need to deal with at home and that there's really nothing that the doctors can help me with my sleep. Up to 80%, I feel like sometimes even more, Parkinson's patient complain of some type of sleep disorder, whether it's trouble falling asleep, whether it's trouble staying asleep, whether they feel like, I slept 10 hours last night, but I still feel really drowsy the next day, or I'm just falling asleep out of nowhere the next day, even though I slept 12 hours overnight. They can have REM sleep behavior disorder, which means that when you are asleep and dreaming, you might be screaming, shouting, waving your arm and kicking your leg, almost like you're acting out your dream. Or people can complain of restless leg syndrome as well. there's a lot of different reasons that people can have trouble staying asleep overnight. One is Parkinson's disease itself can sort of changes your sleep clock a little bit, but sometimes people may need to get up in the middle of the night to go to the bathroom. They may have cramping in the middle of the night that wakes them up. They can have depression, which is another reason that can cause people to have trouble sleeping, or that the medication may need to be a little bit to adjust it a little bit so that it's not wearing off in the middle of the night. You're noticing sort of a resurgence of your tremor in the middle of the night that cause you to wake up. Another sort of, as I mentioned, excessive daytime sleepiness and fatigue is also another part of Parkinson's. Fatigue is actually something a little bit different because people can feel fatigued, like tired, without feeling sleepy. And this is sort of one of the things that is very hard as a doctor for us to treat, because fatigue really doesn't have a specific medication that I can give you. A lot of the time what we do is to make sure there's not an other reason that making you feel tired or sleepy during the day, whether it's from other type of medication, your Parkinson's medication, making sure that your sleep is actually not only just by hours, like you're sleeping a 7 to 8 hour night, but you're also getting a good quality of sleep, that you're not being awakened multiple times throughout the night. A lot of the time we might send you to do a sleep apnea study just to make sure that we're checking all the boxes and making sure that there's not other reason that can worsen your fatigue sort of tiredness during the day. Cognitive and memory changes. The numbers sort of ranges quite widely, from 40 to 80% of patients may develop dementia. This again is usually seen in people with advanced disease, and it's not something that we see early on. Sort of risk factor for having memory or cognitive changes are later age of onset, longer duration of symptom. If people also develop hallucination or depressive symptoms, then they're more likely to also develop dementia as part of their Parkinson's disease. On the milder side, before developing dementia, some patients with Parkinson's may complain of trouble with multitasking. They may have issue with decision making. They may have trouble with sort of figuring out where they are in space, or generally get lost a little bit more easily, especially when they're in unfamiliar spaces. And then the last, I believe, of the non-motor finding is skin findings. And sometimes this, again, is sort of forgotten as part of the conversation when you're seeing your doctors. But actually, Parkinson's can cause skin findings. Parkinson's can develop these kind of scaly, dry skin in different part of their, like whether it's on their scalp, whether it's on their trunk or behind their ears. That these can sometimes get better with sort of topical solutions that your primary care doctor or dermatologist can prescribe for you. But I think the biggest and most important things to remember from this slide is that Parkinson's patients are actually a higher risk of developing skin cancer, especially melanoma, compared to general population. So it is our recommendation for all the adults in the United States to get a skin check once a year. But this is extra important in Parkinson's patient, that you need to have your head to toe checked by a skin doctor, or if your primary care doctor is comfortable doing that, you must have them look at your skin everywhere, including your back and different area, just to make sure that you're not developing signs of melanoma, so we can treat it early. Any questions about non-motor symptoms?
So there's two questions in the Q&A. Is the production of dopamine increased or decreased in Parkinson's?
Decreased.
Decreased, okay. And then the average age for nursing home admittance for, I'm assuming that's PD patients, and what's the average length of stay? Do you have that information?
I don't, and I guess there is different. I guess to answer the average length of stay, I guess it really depends on the reason for nursing home placement. There's a lot. I think majority of my Parkinson's patient does not require nursing home placement, and I think sometimes when they do, it's more related to other complications, say they may sustain a fall and then causing a hip fracture, needing a hip replacement, and that may lead to a short nursing home stay. If patients, when they are, say they're more in the sort of cognitive impaired dementia range, they suffer from a pneumonia or a urinary tract infection, and they just needed a little bit more time to sort of get back to their baseline, that may require a nursing home stay. But longer term, I think, when there is advanced disease that the patients are not able to be managed at home, whether it's from a motor perspective where they're falling all the time, or it's just not a environment that allow wheelchair or people to transfer in and out of bed, or more cognitive changes where they are more demented and having behavioral issues that is hard for the caregiver to manage at home. Those are the more reasons to look into sort of a home placement, just so that people can be in a safer environment. But yeah, I don't have a number in terms of the average age or like duration, like in terms of, until, 15 years from now, I need to be looking into a nursing home. I don't have those kind of numbers.
Sure. And it varies so greatly by person and their personal situation. Yeah. And then do you know why there is an increase in skin cancer? Like why it's more prevalent?
Yeah. So melanoma, it is also, I guess, related to the dopamine changes. I guess that will be the simplest way to put it.
Okay. Thank you. That's it in the chat.
Thank you. Okay, so we're moving on to talk about diagnosis of Parkinson's disease. So despite knowing Parkinson's disease for over 200 years now, we still really depend on physical exam as a diagnosis of Parkinson's disease. There's really not one reliable blood test or brain scan that can 100% confirm Parkinson's disease. What we use in clinic to diagnose Parkinson's disease is one, talking to you, learning about what your symptoms are, learning about what has changed over the year. Two, doing a physical exam, looking for the asymmetry, looking for tremors, the slowness, the stiffness, looking at your walking, to put all these pictures together to say, okay, I think your symptom and your story is most consistent with Parkinson's disease. Then we usually try you on medication. We put you on Parkinson's medication and see how you respond, because by definition, Parkinson's disease is responsive to Parkinson's medication. So we'll try you on a good set of medication. If you say, great, my tremor has gone away now that I start taking carbidopa-levodopa, then we are pretty confident that you have Parkinson's disease. Similarly, if we throw a bunch of medication at you and you are like, I have no improvement whatsoever with any of these medication, then your doctor really needs to rethink about your diagnosis. Imaging like an MRI of the brain, CAT scan of the brain is usually not required unless there is a red flag on your symptom. There is something that on your exam that is not consistent to Parkinson's, something in your history that is not consistent with Parkinson's, then we might think about using other imaging modality to help us rule out other possibilities. But MRI of the brain actually does not rule in Parkinson's, because MRI in Parkinson's patients generally are normal, and we don't. So that's why we don't always need to use it as part of our diagnosis for Parkinson's disease. So it might feel a little strange when you go see your doctor, and your doctor, after talking to you about 30 minutes and say, you have Parkinson's, and you might feel like, what about blood tests? What about imaging? But really, this is a diagnosis, what we call a clinical diagnosis, where we really make the diagnosis by talking to you and examining you. So in the last few minutes, we'll be just talking about a broad picture of treatment strategy, which I will spend a little bit more time tomorrow talking about each individual medication, but sort of the overarching theme of the treatment. So first is medication. So Parkinson's, when we are thinking about medication or treating Parkinson's disease, we're really thinking about medication. The medication in Parkinson's is really to help with the symptoms. It doesn't really sort of stop the progression of Parkinson's disease or halt your disease at that stage, but mostly to help improve the symptom that you're experiencing from your Parkinson's. One thing that many other sort of subspecialty doctors, cardiologists or your kidney doctors may laugh at us, because us Parkinson's doctor really like to do something called polypharmacy, which is not a lot of sort of commonly practiced in the medical world, because everybody wanted to simplify medication. But in the world of Parkinson's, we like to use different type of medication, but at low doses, so we can give you the benefit of these medication without causing side effects. So a lot of the time you might be thinking, why is my doctor sort of adding a third medication while there's room to go up more on my first medication? And then the reasoning may be that we're trying to minimize the side side effect and using medication that works a little bit differently to help improve your function. It is also very important to take your medication on a schedule, on a regimen. This way you can sort of know whether or not your reaction to medication is influenced by the food intake. You are also going to be able to better tell your doctor, hey, I think, my medication is wearing out early, and I feel like, my morning is not as well as my afternoon. So is there any way that I can change around the timing that I take my medication so my day can be a little bit smoother and not affected as much by sort of my fluctuating symptoms? Sometimes we talked about tricks to help the dose kick in a little bit more consistently, and like such as chewing the medication, the carbidopa levodopa, or taking it with sparkling drink, etc. But I think at the end of the day, the goal with all these medications is really to improve your symptoms so you can keep active, so you can keep engaging in physical exercises. Because what we feel like right now, based on our understanding of Parkinson, is that exercise is really going to be the key. So it's not just physical exercises, but also social interaction, getting your brain cognitive exercises, like engaging in different kind of social activities, meeting new people, sharing your experience, doing crossword puzzles, doing Sudoku, things that stimulate your brain. All of these things are going to really be our goal with all the Parkinson's medication, is to keep you active in many different ways. There's also surgical management when we are sort of running out of medication option, or if we're running into situations where we're either having side effect from medication, or you're having symptoms that is not adequately controlled with medication, then we can think about surgical management. But we don't usually think about this for people who are just recently diagnosed. So I'm not going to spend a lot more time in this, but surgery intervention is an option for Parkinson's patients down the line. As a movement disorder specialist, we always talked about how it is very important to have a team behind you for your Parkinson's disease. So the team really involves you and your neurologist that you can work with in terms of titrating medication, talking about new symptoms, talking about how you respond to your old symptoms, and what can we figure out to make your day a little bit smoother and not having this roller coaster of having good symptom control, bad symptom control, and etc. But it's also very important to think about other people in the team, such as therapists, physical therapists helping you with, exercise. If you also have back pain from other reason, how can I be engaged in exercises for my Parkinson's, but also minimize sort of exacerbation of my back pain? Occupational therapists can be very helpful in thinking about activities of daily living. How can I be faster in putting out my socks and tying my shoes? How can I be faster to button my shirt? Are there ways that I can, go about my day still engage doing chores throughout the house, but a little bit safer? Speech therapists can be very helpful when you're noticing that your speech is not as loud and not projective. They can help you work doing certain kind of exercises to help you speak louder. If you're thinking about deep brain stimulation, you want a surgeon on your team as well. Your primary care doctor and your dermatologist is going to be important in sort of looking at your skin, making sure you're not having sort of signs of skin cancer. Your primary care doctor is also going to be very important as part of the team, so then they can oversee all the specialists you're seeing, whether or not it's your cardiologist, your kidney doctor, your neurologist, to put the picture together and help coordinate your care. So having a good primary care doctor that you like is also going to be very important. I'm not going to spend time. I already sort of alluded to sort of my view on the importance of exercise and physical therapy. And I know that Dr. Nate Coomer is going to spend an hour with you next week talking about exercise. But I just wanted to say that is something very important and something that you should definitely consider. Another sort of team members that you wanted to consider that sometimes doesn't really jump to sort of your doctor or your primary care doctor's mind immediately are people like palliative care doctor and social worker. Those two are the people that I think about that can help you with long-term planning. It's either or if you wanted to have both, they're going to be great. So palliative care doctor really focuses on improving quality of life. What is important to you? What is important to your family? How can we better plan your long-term goal so that we can stay consistent to what is important to you? And when they looked at patients with Parkinson's disease that have a palliative care doctor on their team versus those who are not. The people who have palliative care doctor on their team tend to express that less anxiety and less grief about their symptoms. So it's definitely something that you wanted to think about. Social worker too can help you with long-term planning. What kind of resources do I need to help me? Do I apply for Social Security? What about my insurance planning? What about long-term planning? Social worker are also very important as a member of the team. Rehab psychologists and rehab counseling are a little bit more specialized and may not be available sort of in all the cities around the United States, but they are sometimes tools that I would like to ask to reach for help when in certain situations. So rehab psychologists are psychologists who are very good at talking to people, helping them to cope with changes, helping them to manage different stress about seeing doctors. I'm developing new symptoms. How do I cope with this? How do I think about this in a different way so that it's sort of it's not impacting on my mood? Rehab counseling is for people who are still working that and then started developing Parkinson's disease that can work with rehab counselor on job accommodations if needed. So these are sort of people that you might want to consider if it's sort of right for you. It should be part of your team. So coming back, I think at the end of the day, in terms of managing Parkinson's, the most important thing is working with your doctor so that we can come up with a plan that is right for you. And then that can get you to exercise and go out and enjoy and having the best quality of your life. So that is what I have today. And I know we have a few minutes if anybody have any questions.
Okay. I love your puppy. You wanna unshare your screen and we'll pop everybody up here are there any questions? There is one question. Can you talk a little bit more about meal and protein interaction and also about sparkling water? I get this question all the time. So
Yeah.
what do you say?
Yeah. So this is only related to carbidopa-levodopa and not the other Parkinson's medication. So in carbidopa-levodopa, there is, I guess, a big part of the population with Parkinson's disease, they will notice a significant interaction between carbidopa-levodopa and protein. So if you take those two things too close together, the carbidopa-levodopa may not work as well. The way that we think about it is that if I take carbidopa-levodopa and then immediately I start eating a Reuben sandwich that has a lot of meat in it. So both of these items going to go into my stomach. They're going to make their way into the small intestine where the carbidopa-levodopa is being absorbed. But then there's also that Reuben sandwich saying, hey, I have protein, absorb me, absorb me. So your body will preferentially take over the protein and ignore the carbidopa-levodopa. So that making the dose does not work as well. There's definitely a population where they can take a steak with a carbidopa-levodopa and not notice a difference at all. But generally speaking, we still recommend taking it away from meal just so that you can be a little bit more consistent in your absorption. Our general recommendation is taking it an hour before or 2 hours after meal. Obviously, if you are taking medication 5 or 6 times a day, that can get a little bit challenging in terms of meal planning, which is why another reason that we recommend taking the medication at a regimented time so that you can better plan what time should I have breakfast, what time should I have lunch and dinner, instead of sort of trying to figure out day by day. That can be another source of stress.
Okay. And sparkly, taking it with something sparkling, how does that benefit?
Yeah, so I lumped the chewing and sparkling together because I sort of think of it as the same way. So chewing the carbidopa-levodopa immediate release, don't chew your extended release, but for the immediate release, the yellow round pill, if you chew it and or if you take it with fizzy water, so like sparkling water, any sparkling drink, it may actually help the absorption start a little bit faster. So if you're the kind of person who feel like, oh, I take my medication and an hour later, it finally started to kick in, that's a long time to wait, especially say when you first wake up in the morning, you really need the medication to kick in to get your day going, then you can try chewing it and or you can actually chew it and take it with fizzy water as well to see if it can help you kick in a little bit faster. Same goes to I'm like an hour and 30 minutes late from the time that I'm supposed to take my medication. And now I have to wait another 30 minutes for it to kick in. Maybe this is the way, the tip, the trick that you can try to do to help this dose to kick in a little bit faster. This only apply for the immediate release. Do not do it for other medication or the extended release because it works a little bit differently. But for the carbidopa, levodopa immediate release, this is something that you can try to do.
Okay, great. So anyone else have any questions? You are welcome to unmute yourself and ask your question via voice versus typing if you would like. I know I told you it was like drinking from a water hose or a fire hose or a water hose. So it's a lot of information to absorb for sure.
We just wanted to know, is the production of dopamine increased or decreased in Parkinson's? We kind of didn't pay attention.
Decreased. And we'll talk a little bit about, so it is important to know that dopamine is decreased because all the medication that Parkinson's medication we're giving you essentially is to help boost the dopamine in the brain. So dopamine is reduced in Parkinson's. And I think Mary Ann have a question.
I did, yes. Thank you. And thank you so much for the presentation. It's very helpful. My husband was just diagnosed last week. The doctor said at this point that unless he feels like he's not able to function the way he wants to, he doesn't need any medications at this point. Is that common? And what do you have to say about that?
Yes, that is very common. It's actually one of the slides that we're going to be talking about tomorrow as well. So the decision of when to start medication and which medications to start is definitely a very personalized decision. It really depends on the severity of symptoms and also depends on how much the symptom is bothering him. So it is actually not uncommon for us to say, let us just see how things are, get exercise going, and see if you're really bothered by symptoms, then we can talk about starting a medication. I think Parkinson's, Parkinson's disease is I think sometimes a little bit different than a lot of other medical diseases that you may have interaction with the medical field for, just because Parkinson's disease, a lot of it is really about how we can let the medication work with your daily style. So the type of medication that you want to be, the dose that you want it to be, how frequently throughout the day, is it time to talk about surgical intervention? It is really not a dictatorship on the doctor. It's more about me talking to you, learning about what's important, and then my goal and your goal, and then figuring out from there. And there's a lot of different the patient has a lot of input and a lot of say in terms of how it works for them. So for me, it's a lot more about more negotiation than me saying, start your lisinopril at 10 milligrams a day to drop your blood pressure. Yeah.
Mm-hmm. I have one follow-up question. I'm noticing a lot of apathy, some depression, and he's on an antidepressant, but this particular doctor has upped it. He saw a movement specialist for an evaluation. Is that the doctor that he's going to be seeing? I know you don't really know, or does he see his neurologist who he has been seeing for his epilepsy?
Yeah, so the answer is twofold. One is location, and then the other one is how comfortable the epilepsy doctor is with Parkinson's disease. I usually say it's always a good idea to have a doctor close to you physically, because it would be hard to travel 6 hours or 4 hours to see a doctor, especially when things like, you really need it to be evaluated quickly. It's always good to have a local doctor. If your epilepsy doctor, somebody that you know for a long time and feel comfortable managing with consultant from the movement neurologist, that's also another way to go. I often share patients with my colleague in the community. So say somebody is needing to travel 4 hours to come to Seattle, what I would do is that I will see them every 6 months as a movement specialist to make recommendation about their Parkinson's, and then they can see their local doctor a little bit more frequently, and I'm here if they need a question that I can help them answer as well.
Very good. Thank you very much.
So other questions, there is a question in the chat asking about medications working best for tremors, but you're going to be covering that tomorrow. So we're going to save the medication specific questions for tomorrow. Any other questions from you folks in the audience before we wrap up today?
Yes, I have one.
Yes.
Movement specialist. I'm recently diagnosed and have just a neurologist. How do I find a movement specialist?
Yeah. Your phone number looked like you're in Seattle. So
I'm not though.
Oh, okay. So I think does the APDA website have sort of links?
So where are you located?
Chilton,
You're in
Washington.
Shelton. Okay. So I have a list of all specialty trained movement disorder neurologists in Washington State. So I can send that to you. So I'm happy to do that. And then if you're not in this local area, we do have some resources that I can send you to. I know that the Movement Disorder Society actually has a list of folks on their website. So it's a place that I will go to find somebody outside the area. But I'm pretty aware of anybody in our 5-state region that is specialty trained in movement disorders.
Okay. All right. So how would you?
Yeah, go ahead, and since I only have your phone number here, why don't you email me and then I can send you that list, okay?
Okay, great.
Yeah.
How do I email you?
So I'll put it in the chat.
Okay.
I will put that in the chat and then everybody can have that. I'll put our general email in there. Any other questions while I type this in?
I think there's a question about, do you have a list for Southern California?
I don't have a list for Southern California, but I can direct you to where you could search for somebody in your area. So email me that and I'll send you a link to where you'll find that. And I just put our general box in there. It's also, the reminder email would have come that way as well.
Could you please put the email address back up on the screen for just a minute?
I'll retype it up here.
Thank you.
It'll pop up. And that's it. This will be the email address. You will get the post program, the link to the video, things like that. So I will wait until after tomorrow's program to send you Dr. Lynn's presentation and the link to the recording of this. So I'll wait until after that to provide that to you. And the one thing I wanted to just show you is we have 2 resources that are available to you for free. Well, we have more than that, but there is a Parkinson's disease handbook, which is a nice general informational booklet that you can have at your house to flip through if you're looking for something, as well as a booklet about exercise. We also have a book about your voice as well, making your voice heard. So all of these materials, as well as a bunch of different brochures and stuff, are available to you. So if you want me to mail these to you, all of them or just one of them, you can also use that email address to send that to me and I can mail that out. Or they are also available on the APDA website in downloadable versions. So they are a resource for you that are free of charge for you to access. So any other questions before we wrap up? I said it was till 1:15 and we're a couple minutes left. So anything else, burning questions for Dr. Lynn today? She's going to be with us.
Just a big thank you. It was wonderful. Thank you.
Yes.
Bit bigger. Okay, so today is part 2 of sort of our Parkinson's disease, and mostly focusing on medication and some other treatment options. Again, feel free to let me know if you have any questions. You can, definitely unmute yourself and let me know. The very first few slides, we're just going to do a quick review of what we talked about yesterday. And I think some of you guys are not able to join us or maybe join us late yesterday. So we'll do a very brief review of Parkinson's symptoms and what is Parkinson's disease. Then we'll sort of go into the meat of this talk, which is mostly about medication management and sort of the philosophy of medication management. And to give credit to Dr. Sue, who Jen actually mentioned earlier, she gave this talk, I think, earlier this year. So I borrowed some of the slides from her. So I wanted to make sure that I definitely give her credit for that. Okay, so just a few review of Parkinson's disease. Parkinson's disease, what we call a neurodegenerative disorder, meaning that it's a neurological disorder that slowly get worse with time. It is the number 2 most commonly diagnosed neurodegenerative disorder right after Alzheimer's disease. The Parkinson's disease is due to loss of cells that make dopamine in the brain, so that you have less dopamine in the brain, which cause many of the symptoms that people are experiencing. The biggest risk factor is age. And currently there is really not a medication or any kind of intervention that can cure or slow down the disease progression. Parkinson's disease is very costly to not just the patient or their family, but also to the society. The combined direct and indirect costs, so things like Social Security, taking time off from work, remodeling the house, etc., is estimated to be around $52 billion per year just in the United States alone. The big motor symptoms that we think about in Parkinson's are summarized in the mnemonic TRAP, T-R-A-P, standing for tremor, rigidity, akinesia or slowness of movement, and postural instability. Tremor is usually a resting tremor that happens in the hand and is smaller in amplitude and far away from our body, so not involving the shoulder, mostly involving the hand, is the kind of resting tremor that we most commonly see in Parkinson's patient. Rigidity is a it's a stiffness in sort of muscles and joints, and that can involve bigger joints like the head and neck region, shoulders, wrists, but also smaller joints people can feel like it's just stiffer and harder to move around. When doctors test it in clinic, we ask you to relax as much as you can, and we try to move around these bigger joints to see if we need to put in any force to get it to move the whole range that we expect your joint is able to move. So as you see in this gentleman, the examiner needs to put in a lot more force to really rotate his head and his neck. And then bradykinesia, using the same gentleman as an example, bradykinesia is really just means slowness in movement, and it can affect a lot of different part of our body, even things that we may not think about. So things like facial expression. For people with Parkinson's disease, they have slowness in their facial expression, so they're not blinking as much. They may not be as animated when they're talking. When they're moving around, they're not moving as fast. So when we take a look at this
it's very difficult
gentleman right here, you're noticing that he really doesn't have a lot of facial expression, and he's really not blinking very much, that he's just kind of staring at the camera. On the right here is a picture of an example of what we call micrographia, which is a symptom in Parkinson's where it affects your handwriting, where when you try to write, you might try to write a big letters, but the more that you write, the smaller it gets and almost look like chicken scratch. So it's giving you a reference that this is 2 centimeters, and this is how small Parkinson's patients may be writing. So bradykinesia is slowness in movement. Bradykinesia can also affect the lower extremities, which leading to changes in people's gait. So this is the reason that people are noticing shuffling of their gait. They're taking smaller steps as they go forward, and they're not walking as fast. Some patients may also experience something called freezing of gait, meaning that when you're walking, suddenly it's become harder and harder to take the next step forward. You may just feel like you're getting stuck in that position. So here is an example of a patient with freezing of gait. So you start off by taking smaller steps, a little bit of a shuffling. And then here is where you see that he sort of suddenly gets stuck, and he really needs to think and analyze and figure out how to get the next step walking. So that's an example of freezing of gait. Parkinson's can also cause balance change. And then when people lose balance, they may have a hard time sort of catching themselves and right themselves. A lot of the time, it usually just ended up leading to a fall. The way that we test these kind of balance in clinic is by pulling you from the back and see how many steps the patient needs to take to catch himself. Sometimes the patient will just fall spontaneously back, or even without us sort of pulling them, and those are usually seen in patients with more advanced Parkinson's disease. There's also a lot of other symptoms that is harder for other people to see when they're just looking at you. And they might notice people's tremor. They might notice you're not smiling as much, that you are slower in walking, slower in doing things. But there's also a lot of what we call non-motor symptoms that can be very bothersome, or even more bothersome than the tremor. And that is just harder for other people to sort of imagine, or they didn't even know to ask you that, do you also have these other symptoms, and how are you doing with some of these other symptoms? So we also talked about this yesterday in terms of the overarching theme of treatment. Again, the most important thing is that you wanted to make sure that you're gathering a team for your Parkinson's disease. I think a team-based or a multidisciplinary approach is going to be sort of the best way moving forward, because it is more than just one type. It is more than just one symptom, right? So you wanted to make sure that you have a neurologist who can talk about the symptom with you, who can help you titrate the medication and figuring out, should we add a medication? Should we think about how do we rearrange your daily medication so that it works better with your life? So you want a neurologist to help you with medication titration. You wanted to think about having therapists like physical therapists, occupational therapists, speech therapists, to help sort of navigate around throughout your daily activity to see how is it that I can prevent myself from falling? What kind of exercise I can do at home safely? Do I need a shower chair? Do I need something else? So the therapist is going to be very important, sort of thinking about making your daily life a little bit easier and safer. You wanted to think about, getting people on your team who can talk to you about long-term planning. What should I think about in the future? Do I need an advance directive? What is important for me in terms of my quality of life? Sometimes, depending on what kind of other symptom that you have, people might benefit from having a psychiatrist. You wanted to make sure that you are having a skin check once a year, because Parkinson's patients are higher risk of skin cancer, especially melanoma. So sometimes you might want to involve a dermatologist to be part of your team as well. The treatment goal for Parkinson's patient is really a symptomatic treatment. Right now, like I mentioned earlier, that we don't have a medication that can stop Parkinson's from getting worse. There is not a medication that we can cure Parkinson's disease. So really, all the medication that I'm going to be talking about today focus on treating the symptoms. And then by treating the symptom, our goal is to make sure that the patient is actually as independent for as long as possible. And a lot of the time, this kind of it depends on a lot of personalization, because some people's activity level are very different, and what is important to one patient may not be important for another one. So the amount of medication, the way that we're taking medication, and the type of medication choice is very much a negotiation as well as sort of individualized approach. We sometimes think about both medications as well as non-medication therapies, like a therapist, counseling session, etc. And a lot of the time we might wanted to think about, I think this is mine, not yet, but so, our goal is to make sure that we are going to achieve as much of a symptom control as we can while we minimize side effects from these medications. So this is kind of our overarching theme in terms of when we're thinking about medication. This is kind of our goal, is really to keep patients functionally as independent for as long as possible and really achieving that quality of life. So I throwing the slides yesterday thinking just to go over two different concepts because I realized that as I was talking through medications that a lot of these concepts just keep on happening, sort of recurring. So I think just to cover two complications, the idea of these complications, just so that we can be all on the same page and you guys know what I'm going to be talking about when I go into specific details of these medication. So two terms that is going to come up. One is called motor fluctuation. This really sometimes we're referring to as the on-off, like are you coming, like is your medication kicking in? Are you in the on period, or is the medication wearing off? Are you in the off period? So motor fluctuation really just describe the symptoms. Like people can feel like I'm doing very well. I have very minimum symptom of Parkinson's, but at other stages during the day, they may notice that I'm actually having quite a bit of symptom, just like as if almost as if I'm not taking any medication at all. So really this means how much you're responding to the medication. So when the medication is working, people feel like, yeah, my symptom is pretty well controlled. When a medication is not working, they may realize the tremor is back, they're slower, their walking is not as steady. In patients who are sort of milder symptom with the early Parkinson's, they're maybe only taking medication 1 or 2 or 3 times a day. And even if they're late for a couple hours, they really don't notice much of a difference. They feel like they're pretty even keeled throughout the day. They don't notice a big change in their symptom, even if they miss a dose or even if they're late for a couple hours for a dose. Many years later, when the disease progressed a little bit, patient may start to realize, yeah, I have to be really on top of my medication. If I am 30 minutes late, I can tell my tremor is coming back in my left hand, and I really need to rush to get my next dose on just so that I can avoid having a big drop in my symptom. In patients with more advanced Parkinson's, they may feel like I take a medication, it worked great, but it's wearing off much quicker than my next dose. Sometimes it never really kick in at all. Sometimes I get great response with this medication, but then the next time I'm taking it just the right time, just the same dose, but I'm not getting as much of a response. It's a little bit more erratic. So as the disease progresses, people may see more of these motor fluctuation. And it also depends on the timing of the medication as well. So this is one sort of concept. And then the other concept is something called dyskinesia. And this is thought to be a interplay between medication dosing and the motor fluctuation. So when we go back to this slide here, to use a very medical term that I call the sweet spot, if you think about, I don't know if you guys can see my arrow, but if you think about sort of the middle part where they call the therapeutic range, that's the sweet spot. When you take a medication, sometimes the medication can overshoot the sweet spot. And then that's at the point where you started to get the dyskinesia, the wiggling movement. And then as the medication wear off, you sort of get the dyskinesia goes away. And then it may reappear with the next dose. So dyskinesia is really a combination from Parkinson's disease as well as the medication that you take. The interesting thing is that dyskinesia most of the time does not really bother the patient themselves. They actually feel better when they're dyskinetic because their medication is working. They feel like they're smooth, they're not shaking, they're pretty fast in terms of doing things. And sometimes it can actually bother the family member more because it can be quite dramatic looking. So this is Michael J. Fox in one of his interviews, and you can see quite obviously that his having a lot of dyskinesia, these kind of truncal movement, his head movement, and all of these can be dyskinesia. It doesn't necessarily have to be this severe in degree. Some patients may just notice that when they're brushing their teeth, their body may sway back and forth a little bit. Some people, mostly it's in the neck or in the hand. So people's dyskinesia can look a little bit different, but we use it to describe these kind of involuntary movement that people get when the medication is working. Any question about those, what I just said, especially about those two concepts about motor fluctuation and dyskinesia before I move on to talk about individual medication? No.
What does the word dyskinesia mean?
Yeah, so kinesia is movement, dys meaning dysfunctional. So it's abnormal movement. That's essentially what the word really means. But in our world, it really means abnormal movement related to a medication.
Thank you.
Mm-hmm.
Dr. Lin, there was a question in the chat. When you first start to take carbidopa levodopa, how quickly does it work? That day, or does it take a little longer?
It depends. Depends on the severity of symptoms. Sometimes you might not see. So carbidopa levodopa start getting into your system pretty right away. But sometimes you need to take until you have to slowly work your dose up until you're at the right dose in order to see benefit. So for some patients, it could be the first couple days that they started to notice, oh yeah, I'm noticing a difference because now I'm taking one pill 3 times a day. But for some patients, especially if they have a little bit more symptoms, they may not see quite a dramatic difference until they make their way up to 6 to 8 pills a day. So it's a little bit different in terms of from person to person. And I would say that if you only try carbidopa levodopa for a week, you don't notice a big difference. I wouldn't necessarily say that you didn't respond to the medication. It's probably just that you're not taking high enough dose. It's almost like taking Tylenol. Like you have a headache and you take a 325 Tylenol, you're like, doesn't really do it. I have to have the extra strength. That's kind of the dosing that we're trying to adjust.
Does it vary pretty greatly by person because of, how fast their gut moves and, what's in their system? Because it's going through that system, right? So
Yeah. And it's not uncommon, actually. Sometimes we see patients that comes in and then they're like, we tried 8 pills a day and it doesn't seem to do anything for my Parkinson's disease. And then when we talk to them, you realize that they're taking it right when they're eating. So they're taking it with breakfast, lunch, and dinner. And then their pharmacist may be saying that, oh, you wanted to make sure that you don't take it on an empty stomach. So they eat a snack when they take their last dose. And a lot of the time we see sort of the medication not being ineffective also because there's other factors into it as well.
Okay, great. Thanks.
Thank you.
What does the medication actually do? Does it increase the dopamine? What does it do?
Yeah, we'll talk about them. Depends on which one you're talking about, right? So we're going to be going over sort of individually, all of them. Okay, so moving on to medication. So like I was mentioning earlier, Parkinson's disease right now, I think what we understand it is that it is related to not having enough dopamine in the brain. So we all have these cells that makes dopamine. For some reason in Parkinson's patient, these cells are not making the dopamine that we need anymore. They're either making less or not making it at all. So the predominant medication intervention that we're doing for Parkinson's patient is we're finding a way to try to get your dopamine higher in the brain. So we can either by giving you actual dopamine, the carbidopa levodopa, we can give you mimickers, we can give you medication that prevent the dopamine from breaking down, and we'll talk about them individually. But the main state of treatment is really to help the dopamine to work a little longer in your brain. So that's the whole goal of the medication in Parkinson's treatment. So this was what I was wanting to mention earlier. So I talked about this yesterday too. So sometimes what we do in the Parkinson's world, which can be a little bit confusing to the patient and maybe some of your sort of primary care doctor as well, is that we actually do quite a bit of what we call polypharmacy when we think about Parkinson's medication. So when you look at this sort of map, there's many different ways that we can intervene to increase the dopamine. Sometimes what we do is that we do low dose of different ones on this map. So we're coming at it at all different angles so that we can boost the dopamine from all different ways. And this actually may help us minimize the side effects from one medication if we push it up to a really high dose. Sometimes we do low dose, but multiple different medications. So polypharmacy is actually something that we do quite a bit in Parkinson's disease, which is sometimes a little bit shocking to patients and to providers. So the first medication that we're going to talk about is really carbidopa levodopa. I just have a patient this morning who said that this is quite a mouthful to say, carbidopa levodopa. This is the gold standard and also the most powerful, the most potent medication that we have in Parkinson's disease. The brand name is called Sinemet. But right now the generic work just as well, and it's also very cheap. So I don't think the brand is actually prescribed very frequently now. So the reason that carbidopa levodopa has such a long name is because it's actually a combination of 2 different medications. The carbidopa is one medication and it has its own dose. If you look at the bottle, it says 25 usually or 50. And then there's the levodopa, which is the second number, usually a bigger number, around 100 or 200 is usually the common number. So levodopa, the second one, the bigger number, is actually the one that we want to go into your brain, because levodopa, once it get into your brain will work on it and it becomes dopamine. So essentially we're giving you the dopamine that your brain is not producing by giving you levodopa. When they first come out with this medication, it takes a lot of the doses of the levodopa in order to make it into the brain, just because your gut will break it down, so it doesn't really get into the brain. And also it caused a lot of side effects, like people were vomiting all over the place, they're feeling really lightheaded, really nauseated. They couldn't really tolerate the high enough dose in order for it to make it into the brain to work. So the scientists then add on this medication called carbidopa. So carbidopa doesn't really get into the brain to work. What carbidopa do is that it helps the levodopa to get into the brain. So carbidopa works in the gut so that they can prevent the levodopa from being broken down in the gut. And then more of the levodopa then actually can go into the brain and does its work. And also you see less side effect from the combination medication. So the brand name actually Cinemet, meaning no emesis, no vomiting, is because that added the carbidopa to the levodopa. So people are not vomiting as much when they have a combination. So levodopa is the dose that you're actually getting. So the 100 or the 200 is the dose that you're actually getting. Carbidopa is just the tag along friend to make sure that the medication is working better and have less side effect from it. So carbidopa levodopa is, the pharmaceutical companies are very creative in terms of finding out different formulation of carbidopa levodopa and different dosage of carbidopa levodopa. The most common type of carbidopa levodopa is probably this one right here, the yellow round pill. That is the immediate release 25-100. That's probably the most common prescribed medication in my world. There's the ratio is of carbidopa is the 25. The levodopa is the 100. There's also other ones like 10-100, 25-250. If we sometimes think about changing depending on different situation, but I think the most common one is the 25-100. There is also an extended release version, which is either comes in 25-100 or 50-200. There's names of extended release, control release, sustained action. So all of it just essentially means that it lasts a little bit longer than the immediate release formulation. I think roughly around 6 years ago, maybe, the pharmaceutical company come out with this new medication called Rytary. So it is, the way that I describe it is a super extended release medication. So inside Rytary, it is still carbidopa levodopa, but it has in 3 different little bead size. There is a smaller one that is to act like an immediate release. There's a medium one that act like the control release, the extended release, and there's an even bigger size one that can release the latest, and that is a super control, like super extended release version. So theoretically, Rytary is the longest relief compared in sort of these 3 categories of medication. The last one on the right look a little bit funny. It's called Imbresia. It's actually not a pill that you swallow. It's actually an inhaler that has carbidopa levodopa in it that you just inhale. It is not used as a daily medication. It's more used as a rescue medication we'll talk about in a little bit, but it's also sort of in the family of carbidopa levodopa. The more common thing about carbidopa levodopa is actually we use a combination of variety of different medications. So it is fairly common for people to be on both immediate release and extended release. Sometimes we'll even use a combination of Rytary plus an immediate release medication. So they're not mutually exclusive in any way. We're really just playing around with the doses and the timing to find a combination that work for you. Carbidopa, the tag along friend that I mentioned earlier, sometimes can actually be prescribed individually. So in a 25 milligram tablet. So for those people who are still having side effects despite taking a 25-100 of carbidopa, they're still feeling quite queasy when they're taking it on an empty stomach. Sometimes we add on an additional carbidopa to reduce the side effects. So that is definitely another option as well. But carbidopa, when you take it alone without the levodopa, is not going to have any action for your Parkinson's disease. So a common dosage for the carbidopa levodopa, especially for somebody who are newly diagnosed with Parkinson's disease, is usually 25-100. You take it 1 to 2 tablets 3 to 4 times a day. When we think about adding or exchanging it for extended release, whether it's the longer acting or the Rytary, is when the patients are saying, I'm noticing wearing off between my doses. My dose is only lasting 3 hours, but I need to wait an extra 2 hours for my next dose. You know, those 2 hours are really uncomfortable. Then that's the time that we may say, okay, let's think about switching you to an extended release version to cover that gap. Some patients may say, I take my last dose of medication at around 9 o'clock, But by 3 o'clock in the morning, it's so hard for me to turn around in bed because my medication worn off already. I'm stiff and slow. I get up to go to the bathroom and then my tremor came back and I have a hard time going back to sleep. Sometimes these overnight symptoms, we will then switch your bedtime dose of carbidopa-levodopa to an extended release version to help the nighttime symptom to be a little bit smoother. Similarly, you take your last dose of carbidopa-levodopa at 10 o'clock at night, you wake up 6 o'clock in the morning, that's 8 hours. Yes, 8 hours later, and you feel like my medication is out of my system, my tremor is here, it's so hard for me to get out of bed, it's hard for me to put my clothes on, it takes about 30 minutes for my first dose to kick in, so what can I do? So sometimes then we'll add an extended release at bedtime, so a part of it is still lingering into the day, so to bridge that little gap when you first wake up in the morning. We sometimes use it as a trick medication too. If people are having a lot of side effect with the immediate release version, that we sometimes do the extended release because it has a slower on and a slower off. So it's not having a sort of peak and valley as much. So these are the time that we think about sort of switching over to the extended release medication. And I'll talk about Inbrija a little bit later when we're talking about rescue medication, but that is considered a rescue and we don't advise people to take it regularly 3 times a day as an inhaler. Some of the common side effects with carbidopa-levodopa, GI upset or a little bit of queasiness in the stomach is probably the most common. We do want you to take it on an empty stomach if possible, just because the potential interaction with protein. But if you feel like if I take it completely empty stomach, I'm still feeling a little bit of queasiness, the first thing we will ask you to try is actually taking it with a little bit of saltine crackers, just any kind of crackers that can help you to calm the nausea a little bit. But if that's still a big problem, then we talked about adding the additional carbidopa to it. Carbidopa-levodopa can drop blood pressure. We talked about orthostatic hypotension, which is low blood pressure when you stand up yesterday. And carbidopa-levodopa can actually make that a little bit worse, make people a little bit more prone to have lightheadedness as a potential side effect. At high doses, or people with advanced Parkinson's disease that they already have hallucination, carbidopa-levodopa may make that worse. Dyskinesia, the wiggling movement, is a potential sort of side effect, is really an interplay between the medication and your disease progression. And a small population of patients may have drowsiness associated with carbidopa-levodopa as well. Tips, we mentioned this yesterday too. Some patients will notice that if they take this medication too close to a meal or when they take it with protein, the dose may not work as well. So especially when we are first testing you on a medication to make sure it is a medication that works for you, we generally advise you to take it an hour before or 2 hours after meal. You can take it with cracker, but make sure that you avoid the protein because it fights with the absorption in your gut. Chewing or taking it with fizzy drinks for the immediate release, not the Rytary, not the extended release, only the immediate release. If you chew it and or taking with fizzy drinks may help the absorption start a little bit sooner. So it can help you kickstart with the dose, especially for those people who are like, oh, I'm late for my dose and now I'm going to have to wait another hour for this next dose to kick in. Then you can think about chewing it or taking it with fizzy drinks. The picture in the bottom, I know we're at lunchtime, so it's perfect. But the picture at the bottom is to really remind you that protein actually comes in many different forms. We think about protein, the first thing we think about maybe is meat, like ham and steak and turkey, etc. But there's a lot of other things that also has a lot of protein in it, like pudding. Also like milk and yogurt also has a lot of protein in it as well. Egg is also a protein. So just wanted to make sure that you're a little bit mindful in terms of your choice of food. And then, yep, so I see a question pop up in the chat room. So before we move on, sorry, did I say dizzy? Oh, I mean fizzy with an F. Thank you. I will correct that, but fizzy drinks, like sparkling waters and soda and things like that. So not dizzy drink, do not drink alcohol with this, fizzy drinks. Okay, any question about carbidopa-levodopa? Okay, so moving on to the next, sorry.
I just wonder about any interaction. I'm taking another prescription for depression, the Lexapro. I'm wondering about that with the side effects.
Yeah, so Lexapro does not interact with carbidopa-levodopa. It's an okay medication to take together. It does interact with one of the medication that I will talk about a little bit later, and then I'll make sure that I mention it. But with carbidopa-levodopa, it is okay. And that is really the benefit of carbidopa-levodopa, is that it's actually a pretty safe medication in terms of interaction. It doesn't really interact with other medication that you're taking. So this is actually a pretty sort of easy medication for doctors to prescribe, just because you don't have to worry about a lot of medication interaction. Okay. So the next medication category is called dopamine agonist. So it really means that it is a mimicker. It is a medication that is not dopamine, and it does not become dopamine in the brain, but it acts like dopamine in that it goes to the spot that dopamine would normally go. So it at the end trigger the same kind of activity that dopamine would trigger. So dopamine agonists are medication that is also quite powerful. They're pretty potent medication as well, maybe not to the same degree as carbidopa-levodopa, but they're also a pretty heavy duty medication. However, it may not be for everybody. Let's talk about some of the benefit of these medications. So we generally think about dopamine agonists when we are thinking about younger patients, when they are able to handle more side effects. We think about dopamine agonist. It also lasts a little bit longer compared to the immediate release medication, the carbidopa-levodopa. So if we're thinking about patients with motor fluctuation, dopamine agonists may cover more hours for us. It is sometimes also more helpful in patients with tremors. There are certain patients where, despite taking a lot of carbidopa-levodopa, their walking is better, their slowness is better, but they still have this tremor in their hand that's hard to shake off. Sometimes we think about dopamine agonists for certain population actually work better for their tremor than carbidopa-levodopa. And when you compare sort of relative equivalent dose to dose, the dopamine agonist has a less chance of causing dyskinesia. So when we're thinking about a patient who already has a little bit of dyskinesia, but we're needing to increase the medication for their, say, slowness, then we might not go up on the carbidopa-levodopa. We might choose to add a dopamine agonist instead. So this is the polypharmacy and minimizing side effect. These are the kind of things that we are going to be thinking about when we're sort of going over your symptoms. So there are main 3 types of dopamine agonist. Ropinirole, or the brain name is Requip. There's a variety of different doses that's available for the ropinirole. They also has an extended release version to that as well. And my understanding is the extended release is more expensive. Similarly, for pramipexole or Mirapex, there are also a variety of different doses available, and they also have an extended release version. And then the last one is reticotine patch. It's actually over the skin type of dopamine agonist. It's a 24-hour a day kind of patch. It is not very commonly used because one is that people can have a little bit of skin reaction to the actual patch itself. And because the doses doesn't come in, you can't really cut the patch and, like I wanted a quarter of this much or anything like that. It's harder to titrate in the last 24 hours. So it's not a medication that we very frequently use. And so the dopamine agonist, so one of the questions in the chat room is, can you take a dopamine agonist by itself? So it can be taken by itself. And sometimes that is the medication that we prescribe, especially for people when they started to have Parkinson's symptom in their 30s, 40s, and 50s. Sometimes this is a medication that we start off with even before trying the carbidopa-levodopa. So this medication does work when it takes alone. Back to this slide. So it sounded like a great medication. It works really well, sometimes work better for tremor. It lasts longer. You can take it along without carbidopa-levodopa. It doesn't have as much of a protein interaction. So it sounds great. Why shouldn't everybody be on it? So the problem is that this class of medication also generally has more likelihood of causing side effects. And then the side effects are a little bit more likely, especially when we're looking into a more elderly population. So this is a class of medication that can make doctors a little bit hesitant to put people on. So what are some of the potential side effects? So these medications compared to carbidopa-levodopa are more likely to cause drop in your blood pressure. So you're more likely to feel dizzy and lightheaded with this medication. It can cause leg swelling in the legs. It can cause drowsiness, but also something called sleep attack. meaning that it's not just like when you take a medication and you feel a little bit sleepy, take a nap 10 minutes, you feel better. It's more just that suddenly out of middle of nowhere, you're sitting in traffic in I-5. For those of you who are not from the Seattle area, it's one of our major highways. They tend to get backed up quite frequently. You sit in the traffic and suddenly just get really drowsy and you're like falling asleep behind the wheel. So that can happen, the sleep attack with dopamine agonists. Impulse control disorder are also more likely to happen with dopamine agonists. So this is essentially means a really strong urge that's really hard for people to control. So there are cases describing people spending a lot of money buying and shopping online because they just really wanted, they have the impulse that I wanted to buy. And it's hard for people, for themselves and their family to really control that. It can happen for gambling. Hypersexuality can happen. I have patients gaining a lot of weight because they always wanted to eat sweet food all the time, and that's their impulse. I have heard patients who wanted to exercise 8 hours a day. I mean, exercise is good, but too much exercise can also be dangerous. So impulse control disorder also more likely to happen with dopamine agonists. And then hallucination, seeing things that are not there, also more likely to happen with dopamine agonists. All of these side effects are dose dependent, meaning that it's more likely to happen at the higher doses, and it will go away as we go back down on the doses. So usually our way is that we start at a very low dose and watch you and ask your family to watch your behavior very closely with time. But because these side effects are more likely to happen in the older population, dopamine agonist is usually not our go-to when we're thinking about treating people in their Parkinson's disease. Any questions on dopamine agonist? So the next category of medication is called MAO-B inhibitor. And this is the medication that has more potential of drug-drug interaction. So you just need to be a little bit mindful in talking to your primary care doctor and your neurologist, making sure that your medication is more up to date. But how does this medication work? So this medication does not really give you dopamine or bind to the dopamine receptor in the brain. What it does is that it blocked one of the molecules in the brain that chew up the dopamine. So when your levodopa become dopamine in the brain, and then the cells in the brain that is still producing dopamine, they're still releasing all the dopamine that you need. This medication stop the enzyme that break down the dopamine. So then the dopamine that is still there is able to linger longer and act a little bit longer, so they can still do their job, working extra hours essentially. This medication, because of how it can still sort of, your brain is still producing some dopamine, although not as much before, but this medication is still going to work on the same way from the dopamine that your brain is still producing. So it can also be used as a standalone medication without carbidopa-levodopa, without a dopamine agonist. Because it's benefit, the benefit from this medication in terms of treating the symptom is not as great as the carbidopa-levodopa or dopamine agonist. We only use it as a standalone medication for patients who have relatively mild symptoms. Then we may be able to help them. If they only need a little bit of improvement, this is a medication that we can think about. But far more commonly, this medication is used as an add-on so that we can allow each dose of the carbidopa-levodopa to last a little bit longer. There is one particular medication in this family that may help drowsiness and boost people's energy a little bit. So we talked about fatigue as part of Parkinson's. Sometimes this medication is something that we think about if patients are noticing a lot of fatigue. We say, maybe we'll try selegiline, which is one of the medication, to help to see if that's going to be something that's helpful. The full benefit of this medication can take several weeks to kick in. So it's not like carbidopa-levodopa or dopamine agonist where you may feel the benefit a little bit quicker. This medication, just the way how it works, it requires several weeks to really kick in to see full effect. Same thing, if you stop the medication, you might not notice worsening of your slowness or tremor until several weeks later. This medication actually interact, and then the biggest interaction that I think the pharmacist is going to point out is actually with antidepressant medication. So any SSRIs like Lexapro, Paxil, Celexa, all those medication may have a potential to interact. I wanted to say, so 2017 or a few years before that, they actually did a study to look at how significant is this interaction. And then they looked at many different Parkinson's patients, and they see that if you're only taking one antidepressant, you're not taking more than one, then it's actually safe to add on this medication. But if you're taking 2 or more antidepressant, then it is not recommended to start this medication just because the risk of side effect is too high. So there is 3 medication in this family. The selegiline, rasagiline is probably the most commonly used, and sulfonamide, because it's a newer medication and it's still quite expensive, is not a very commonly prescribed medication. Selegiline is a medication that is taken once or twice a day. It is the one that I talked about that's for some patients, it may help boost their energy a little bit, because selegiline, when it gets into your body, part of the drug that got broken down into actually created an amphetamine byproduct. So amphetamine is like speed, essentially. So that part may actually help boost the energy a little bit. But for some people who already suffer from insomnia, trouble falling asleep at night, this actually may make the insomnia worse. So we generally recommend that if we're still wanting to try it, take the second dose before noon so that we can minimize its effects toward the later in the daytime. But this is a medication that we think about if my patient comes in, they're just a little bit far away from, better symptom control, and that they're having a lot of fatigue and drowsiness, then I say, let's try selegiline and see if we can sort of kill 2 birds with 1 stone. Rasagiline is an easy medication because it's only once a day. You just take it in the morning and you don't have to think about it anymore. It does not have the amphetamine byproduct, so we don't get that energy boost that some patients report they have. But it is also a really good medication to sort of help sort of calm the daytime fluctuation. Any questions on MAO-B inhibitor or any of these medications before I move on to the next category? So the next category is called COMT inhibitor. So this one works a little bit differently in that it is more working on the level of levodopa and not dopamine. The goal for this COMT inhibitor is that it allows levodopa more of it to get into the brain and linger a little bit longer in the brain, and so that it can have more chance to be broken down into dopamine, so to work. So in that case, this medication, when you take it alone, it does not have any effect. It doesn't really do anything other than changing your urine color, which is a side effect of this medication, but it doesn't have any benefit for your Parkinson's symptom if you take it alone. It has to be taken with the carbidopa levodopa. Because how it works is by enhancing the action of carbidopa levodopa. The side effect is pretty similar to carbidopa levodopa, just that make it a little bit more obvious. So the same thing with lightheadedness, dyskinesia, hallucination, etc. The urine color change happened to not everybody, but it's more of what I was told. I've never seen it myself, but I was told it's more of like an orangey kind of color. Is what turned the urine. It's safe. It doesn't hurt the kidney or anything, but it's something that we definitely wanted to tell the patient because sometimes it can be a little bit shocking if we don't tell them ahead of time. So there is currently 3 different versions of COMT inhibitor here in the United States. The most common one is on the left called entacapone. It comes as 1 standard dose, 200 milligram, and you just have to take it with every single dose of the carbidopa levodopa that you take. There is a combination medication called Stalevo, which is they already packaged for it together. So it's carbidopa levodopa plus entacapone. So instead of taking 2 or 3 medication, now you only just take 1 pill. And it comes with all different kind of dosing. And then the dosing is really representing the levodopa in the pill, as the carbidopa is just a ratio, and then entacapone is a standard 200 milligrams. On the right is the newest medication to this family. I wanted to say came out of the market about 2 years ago, so it's still quite expensive, but it's a once a day medication that you take it at night and it lasts all day. So we spent a lot of time talking about different medication that acts on different parts of the brain, but overall with the goal to increase the dopamine level in the brain. That is the mainstay of treatment for Parkinson's symptoms, but we do have a couple other medication that we can sometimes think about that is really not acting on the dopamine pathway, but it also exerts some benefit for Parkinson's patients. So one of the question in the chat room is primidone. So primidone is not a COMT inhibitor. Primidone acts very differently. It's a barbiturate. It acts very differently, so it's not a COMT inhibitor, and it's not a medication that we use for Parkinson's disease. It is a medication that we think about for people with essential tremor. Okay. So we're going to talk about three medication that is not dopaminergic that sometimes we do use in Parkinson's disease. The first one is called amantadine. So we really don't know how exactly amantadine works in general, and we definitely don't know how it really works in Parkinson's disease. This medication actually has many different use in different medical conditions. It has been used in MS patients. It has been used to treat the flu. So as you can see, it probably has multiple different actions, but somehow some people just realize that, hey, it works for Parkinson's. The most commonly the reason that we use amantadine is to reduce the dyskinesia, the wiggly movement. So typically dosing is 100 milligram 1 to 3 times a day, depending on your symptom. There is a fancy version that is once a day extended release. And that one is also sort of pretty new. So it's pretty expensive that an insurance has to approve first. Because this medication has many different actions, as you can imagine, there's also many potential side effects with this medication. I won't read through the whole list, but it is definitely a medication that we need to be careful, especially when we are thinking about people who are a little bit older in terms of trying this medication, is more likely to bring on some of the cognitive side effect and hallucination, etc. The next medication is also a mouthful, trihexyphenidyl, or Artane is the brain name, but it comes in generic form. So it's not a very expensive medication, but it's definitely much easier to pronounce in Artane than trihexyphenidyl. But this medication is under the category of anticholinergic. So it acts not on the dopamine system directly, but they think that it may have a seesaw effect with the dopamine. So, but then at the end of the day, the goal of trying a medication called Artane is to really reduce the tremor. The main target for this is really helping reduce the tremor. It doesn't do very much for the gait or the slowness part. And so this is a medication that we think about when somebody has a lot of tremor or tremor that is not well controlled on their current medication regimen. Again, this medication are more likely to cause side effect. It dries you up. So people are more likely to have dry mouth, dry eyes, causing blurry vision, more likely to get worsening of their constipation or difficulty urinating. And it's also more likely to cause cognitive side effects like confusion and hallucination. So this is not actually a very, despite it's a tremor medication. A lot of Parkinson's patient has tremors. It is not a medication that we grab for immediately just because of the side effect profile, especially in the older population. And the last one is also a new kid on the block. It is a pretty new medication called Neurions or isradefylline. It's approved just a couple years ago. It actually has been in use in Japan for many, many years for Parkinson's disease, but it never really made its way to the United States until now. It is a once-a-day medication. It does not work on the dopamine system. It works on a different pathway called adenosine. And how does the adenosine system and the dopamine system really work together? We're still not sure. We just know that this medication seems to be helpful for Parkinson's patients in reducing the off time, so prolong to make their day a little bit smoother and not so much of an up and down. The side effect is actually pretty similar to the anticholinergic medication that we mentioned. So like dizziness, constipation. It can also enhance some of the carbidopa side effects. So like dyskinesia can also happen with this medication as well. Any questions about the medications that I just went through?
There is a question in the chat. Is primidone a type of COMT inhibitor?
Yeah, so I think I talked about that. So it's not. It is a medication that's a completely different, it's barbiturate. So it's a completely separate medication that we don't use in Parkinson's patient unless you have coexisting essential tremor, then we might consider it, but it's not a Parkinson's medication. It is not a COMT inhibitor.
Great, thanks.
Okay. So some of the questions that we often talked about when we see patients, especially in their initial first or second visit after their diagnosis of Parkinson's disease is, when should I start taking medication? Which one should I start? There's so many medication. And is it safe to start taking carbidopa-levodopa so early? So we'll talk about some of these questions. So as I sort of mentioned earlier, it's really a personal decision when to start taking a medication, because the goal is really for symptomatic control. So if you are the kind of person who are like, I hate taking a medication, no way for me to remember taking it 3 times a day, I only have a mild tremor, doesn't really bother me, I'm doing exercises all day, then I say, sure, let's not start any medication. We'll continue to see you regularly in clinic just to check in with each other, check on your exam, make sure you're not developing worsening symptoms. Then we say, let's hold off on starting medication. Sometimes it's definitely a little bit more negotiation and sort of like case by case and very personal decision. I do put my feet down sometimes and say I do strongly recommend people taking medication if they're telling me that I'm not bothered by my symptom, but I spend all day sitting on a couch because I have a hard time getting out, but doesn't bother me. I'll just watch Jerry Springer all day. In those situations that I would say, actually, no, let's try to see if we can use a medication to help you get easier moving around so I can get you back into exercise, get you back into physical therapy. But for people with milder symptom and still staying very active during the day, then I say, sure, we can decide whenever you're ready to take a medication, then we can talk about that more. So that's kind of my sort of philosophy in terms of when should we take a medication. The next question then is, which medication should I take? Again, this is a lot depends on sort of personal preference and your symptoms. There are certain times where you have really, really mild symptoms, and we say, sure, let's try selegiline on its own. You only need to take 1 to 2 pills a day, so we don't have to worry about the protein interactions or anything like that. You might say, I only have a tremor, and that's the only symptom I have. Can I try trihexyphenidyl artane on its own? Then we can say, sure, that's definitely possible. If you feel like, I don't want to try carbidopa-levodopa, can I try a dopamine agonist like ropinirole first? It depends on, your symptom. It depends on some other sort of comorbidity that you may have medically. We may say yes or no to that. So there's a lot of different discussion that can happen in terms of which medication to start first. But one thing that we wanted to make sure is that there should not be an aversion to carbidopa-levodopa, because I think there are many different debates that has gone on longer than I have been practicing, that when is it the right time to start carbidopa-levodopa, because there's certainly people in school of thoughts, and doctors included, that some people feel like they should delay starting carbidopa-levodopa because they feel like if they delay starting carbidopa-levodopa, maybe they won't get the dyskinesia like Michael J. Fox as early. Maybe they won't have as much motor fluctuation. So this is a very long slide, and I'm glad that Jen is going to give you a copy of the slides. But essentially what it's saying is that our current belief as a group of movement disorder doctors is that there should not be a reason to delay starting carbidopa-levodopa. We do not think starting carbidopa-levodopa early is going to lead to having motor fluctuation or dyskinesia early. So I think from what we're saying is that we feel like it's safe to start, but again, there's many different reasons that we may choose one medication over the other. So it's not that we definitely have to start carbidopa-levodopa. It's just that we shouldn't avoid starting it just because we're fear of the motor fluctuation or the dyskinesias. Okay. So I think I talked about a lot of this already. So really, starting carbidopa-levodopa is a very individualized choice. And we definitely wanted to make sure that we're starting people on a medication that they are agreeable and that they are willing to try, because forcing a medication on somebody is definitely not what we wanted to do. So there's a lot of education and a lot of discussion that we usually have surrounding medication, and this is a discussion that we're always happy to have with our patients. So how can you help us when you come to see us in clinic? How can you make the most out of that visit? So I talked about some of this yesterday already. So I think having a strict regimen in terms of taking your medication, I always take my medication at 8, 12, 4, then make sure that you're actually sticking to that, because that way we can better tell if there's side effect, how long the medication is working for you. Is there any wearing off? Is there any dyskinesia? That can allow us to better track the symptom that you're having and the relationship with your medication, so that we can better adjust either the timing of the medication or the dosing of the medication better. So whether or not you wanted to sort of keep track of it with phone reminders like an alarm clock, or sometimes I have patients putting a sheet on their refrigerator, they just check out every day that they've taken their medications, having their families and friends reminding them. I think all of them are going to be, whichever way that worked for you, as long as you have a system, it's going to be much better, and it's going to be a much more fruitful conversation when you come back and have this kind of homework to report to us, so we can better titrate your medication for you. There's sort of a lot of different online tools that you can use to track your medication as well. People can be really creative, or if you wanted to be very mathematical and use Excel spreadsheet, go for it. Anything that works for you, as long as you're able to keep track. I think there's also symptom tracker on APDA website as well, that it's on an app. So if you're comfortable using a phone, you can also use that to track your symptom and your medication. So it's almost like your primary care doctor asking you to track your blood pressure at home so they can titrate your medication for you for your blood pressure. It's kind of similar, but it's a little bit more detailed in Parkinson's, just because the medication is taken more regularly throughout the day instead of just once a day, like a blood pressure medication. Any question? So what to expect down the road. We already talked about some of this already. Motor fluctuation and dyskinesia are generally symptoms that we don't see early on in patients' course. It's a more sort of reflective of a progression of disorder. So on the bottom here, you see early PD, moderate symptom, and a more advanced symptoms. And it doesn't necessarily develop in everyone. I have to say that it does develop in most patients that I see, but sometimes it can be years later, sometimes a little bit sooner, depending on when you are diagnosed and how much symptom you have at the time of your diagnosis. But motor fluctuation and dyskinesia are sort of common sort of symptom that we see as the Parkinson's progress with time. So what does it mean? Usually when we start dealing with motor fluctuation, we may try to have you take medication more frequently throughout the day. I think the most extreme case that I have seen in terms of dosing medication is a patient who is taking medication every 2 hours around the clock. And that was before the day of Rytary and deep brain stimulation. But sometimes you just have to take the medication much more frequently. And as you can imagine, that can become very troublesome, because you have to just remind yourself that, every 2 hours I need to take a pill, because otherwise I'm going to feel off. And then if you also need to time it with your meals, you have to be an hour before, 2 hours after. It just gets very hectic. So that can be very sort of challenging to you and your family. Sometimes as the symptom progress and people start to get motor fluctuation, they can also experience something called unpredictable on time and unpredictable off time. So regularly, on average, when they take a medication, it may last 3 hours for them. But sometimes out of nowhere, for no apparent reason, they're not doing anything that is particularly off their routine, the dose just worn off after an hour. Or that they took a dose and then 2 hours later, it still never really kicked in. So there's unpredictability can also happen in some patients as well. And that can also be very challenging. So Ron, I'll get to your question in a little bit. So some of the things that we can do when we are seeing these kind of complications. So I talked about rescue medication. So there is Inbrija, which is an inhaled version of carbidopa levodopa. It is a little bit more sort of challenging to put it together. You have to pull this tube apart, drop a medication in, and then snap it back in, and then hold it in front of you to inhale it. So as you can imagine, when people are having issue with the dexterity or they're having a lot of tremors, you might need to ask your family to help for you. This medication, it bypasses the gut as you start absorbing the carbidopa levodopa in your lung. So they feel like it's gonna work a little bit faster than, say, an hour that sometimes it takes for medication to kick in. Some patients, after using the Inbrija, actually notice that when they cough and then they cough up phlegm, the phlegm can actually look black. And then we talked to the pharmaceutical company. They said it's not because they're damaging the lung in any way, just that the stain from the medication can also sometimes stain the mucus a little bit. So that's the Inbrija. Kimobi is even newer. I wanted to say probably just this year or last year is when they come out. So it is a dopamine agonist. So it's like pramipexole, Mirapex. It is not a carbidopa-levodopa, it's a dopamine agonist. And it is a medication that looks like, I don't know if you guys have tried like Listerine Mint that you can get at grocery store. So it's essentially a little film that you put it on your tongue and for it to dissolve. And that's how it works. So it get absorbed in your mouth. Because if it's a film, it can sometimes cause a little bit of irritation around the mouth. And because it's a dopamine agonist, remember that this is a class of medication that generally has a little bit more side effect profiles. It's almost like giving you a punch of dopamine agonists in the system. So it does have a more likelihood of dropping blood pressure, making people drowsy, etc. So to find the right dose for you does require pretty careful observation, either by your doctor or a nurse from the company. They will help you with this. Before we have all these fancy ways of rescue medication, our tried and true way is actually having you chew and drink a fizzy water. That's a sort of our way of having people sort of get the medication kicking in a little bit sooner. So that is still the tried and true, and that is still the way that we talk to our patient. But there's these other methods. If that one doesn't seem to work, we can think about these options. Duopa, as the name kind of suggested, the OPA also suggested, this is also a way to give you levodopa, but this is not through a pill or an inhaler. This is actually directly putting a levodopa gel into your small intestine where it gets absorbed. So this means that there's going to be a feeding tube that's placed through your stomach, and then they're going to put a little tubing down to the small intestine where the medication gets absorbed. And then the tube is going to be attached to this machine over there. And then there's a cassette that you insert every day. So this is essentially providing you with 16 hours of levodopa continuously. So it minimizes you to need to take any medication throughout the day. You might still need to take medication overnight because there's still that 8-hour gap that assume that you're asleep, that you might need some medication coverage. But during the daytimes for 16 hours, they're able to provide you with constant levodopa. So with the hope that this is going to help the day a little bit more smoother and you're not having the up and down. But as you can imagine, this is a feeding tube, almost like a tube going through your stomach. And then you have to be comfortable doing it. Your caregiver needs to be comfortable sort of managing it. Sometimes the tube can get dislodged. You might need to get a replacement. And this can also lead to sort of a risk of causing sort of infection or inflammation of your gut. So it is not a common procedure that we do, but it is definitely FDA approved and an option for people who are taking a lot of medication throughout the day and also suffering a lot of motor fluctuation. The deep brain stimulation is the most commonly performed surgical intervention for Parkinson's disease. It is not a cure. If it's a cure, Michael J. Fox actually said it himself, this is not a cure, so I don't want it. It is not a cure. It is more of an extension of medication. So if we're running into sort of side effect from the medication, a lot of motor fluctuation, needing to take medications many times throughout the day, or a lot of dyskinesias coming from the medication, then we start thinking about a deep brain stimulation. It is also a treatment that we think about for people who has a lot of tremors that doesn't seem to be responding as adequately to medication. It has been around since the 1990s, and over the past 5 years, there's really an explosion of sort of technology in the deep brain stimulation world. So there's now a lot of different choices, a lot of different ways that can sort of help minimize potential side effect coming from the stimulation itself, but it is still a brain surgery. There is really not a timeline per se for the brain surgery. It's not that, you have to have Parkinson's for 10 years before we can have this discussion. It's really, it's very individualized again about when should we consider deep brain stimulation. And there's also not an age limit for deep brain stimulation. Our surgeon, the way that he said it is really not how many years on a car, is more the mileage in the car, in the sense that as long as you're physically healthy and able to go through a brain surgery with general anesthesia, so healthy heart, healthy lung, then really there's not an age limit cut off. And we have done patients in their 80s for deep brain stimulation. So this is an option for patients when they're having a lot of complications, taking a lot of medications, or having tremors and dyskinesia. This is a potential option for those people who are willing to go through a brain surgery. So to go back to Ron's question before we move on to non-medication, so there is really not natural medication that provides just enough carbidopa, levodopa or dopamine in the brain. Fava beans, F-A-V-A, fava beans actually has a little bit of dopamine in there, like levodopa that gets into dopamine in there. But you'll probably have to take quite a bit in order to see the same benefit that you're going to be seeing with the carbidopa, levodopa. And it's probably also going to make people very gassy. But that's the only sort of natural medication that I can think of. So additional treatment consideration, non-medication treatment consideration. I think you're going to get a whole hour with Nate next week about exercise and physical therapy. And I just wanted to put my personal plug in this. So I tell my patient that if I can prescribe exercise, I will. Because I think my goal for medication, my goal for titrating your medication is really to get you moving and stay active. The next question you might ask is, well, then what type of exercise would recommend? And I would say, depends. So if you're the kind of person who already does a lot of exercise, going to the gym, going out for walks, then I would say, just think about adding different type of exercise throughout the day. So we wanted a mixture of cardiovascular, things that get you huffing and puffing and sweating, and also a little bit of more what we call core strengthening exercises. So exercise that builds up your big muscle group, like your belly, your thigh, and your back, because those kind of exercises are going to be good to help keep your posture straight, help maintain your balance in the long run. So those kind of exercise you can get either from weight training, Tai Chi, which is great because it's a big, slow movement, or yoga and Pilates. Those are good for core strengthening exercise. If you're the kind of person who comes to my clinic, and I actually do have patients come to my clinic and say, Dr. Lin, I really don't like exercising. It's so boring. I can't keep my concentration for more than 5 minutes with exercising. Then I would say, try anything that works for you as long as it gets you moving. I had patients playing virtual reality video games where they're playing like Star Wars, where they're pretending to swing sword and ducking and jumping. If that works, as long as you're moving, I'm happy with that. So as long as I can get you to start moving and get you to realize how good exercise feels to your body, then I think people will start to realize the importance and start getting into a routine of moving. If you tell me that, I have back pain, I have back injury before, if I try to move and walk, I start to get a backache and they'll put me down for 2 days, then I would say, I definitely hear that. And I see a lot of patients with a similar issue, and physical therapy is going to be very helpful because they can help you figure out a regimen that'll work for you and also doesn't exacerbate your back pain. So there's a lot of different ways to get you moving. And that's really my goal and my plug for exercise and physical therapy. There's a group called LSVT Big and Loud. They are sort of exercises that for Parkinson's patient. The big is really to get people to do big movement, is through physical therapy, and loud is to help you project your voice a little bit louder. Those that they're actually, these are exercises for Parkinson's patients as well. So there's another option. Occupational therapy is also very important, and I refer a lot of my patients to occupational therapy because they help you think about daily activities. If you have a tremor that wouldn't go away, that's really difficult for you to eat, should we think about a specialized spoon, a specialized fork to make you eat a little bit easier? If you feel like your balance is a little bit off, should we think about a shower chair? Should we think about adding a bar in your house so that you don't fall? If you have trouble putting on those really tight compression socks because you're feeling lightheaded when you're standing up, is there a tool that can help you put on the socks easier? So occupational therapy is also a very important part of your team that you wanted to make sure that you have if you have the needs. Sometimes we think about medication or treatment option for non-motor symptoms. For people with anxiety and depression, we think about anxiety, depression medications. We talked about blood pressure support yesterday, whether it's through hydration or actual medication to help support your blood pressure. If you're the kind of person who are kicking and screaming and punching people when you're sleeping at night, talking to your doctor about trying melatonin at nighttime may be something that is an option as well. I think sort of the takeaway message is that activity is good. My mentor always say that we wanted to keep our Parkinson's patient physically active. So whether or not it's exercising, walking outside, taking a Pacific Crest Trail for Parkinson's disease with llamas, that's something that interests you. That's also very good for physical activity. Socially active, so going out, support groups, hanging out with family, meeting new friends, that's also very, very important. And cognitively active, so reading, meeting new people, doing puzzles, all of these activities are going to be our goal in terms of managing your medication so you can do all of this. Finally, if you are interested in research, there's many, many different ways of being involved. There is clinical trial information on APDA website. If you're in the Washington State, we have a Washington State Parkinson's disease registry that take down your information and may send you information if there is any sort of clinical trial that are looking for Parkinson's disease patient. We also have our own registry here at University of Washington, where we're collecting information on our patients to learn about sort of different things that seems to be helpful for Parkinson's patient here, quality improvement project, et cetera, here at UW. There's also Fox Trial Finders, which is more of a national kind of trial information, clinical trial information. Obviously, there's also clinicaltrial.gov as well as Parkinson's Study Group that can also give you information on research that if you wanted to be involved in. So that is all.